section in your books on fluid and electrolyte imbalances. Some pieces of information that are important to know: symptoms of fluid deficit and excess, and then tonicity of IV fluids, whether it's iso, hypo, or hypertonic. Fluid volume imbalances, some things we need to know. Potassium, first one we're going to start with, 3.5 to 5 milliequivalents per liter is the normal range. This helps maintain intracellular ions, and it's involved with cardiac rhythms and nerve transmission. If you remember potassium cardiac, then link sodium with confusion. The normal range of sodium is 135 to 145, and again, to maintain extracellular ions, and it's responsible for water balance. Whether sodium is high or low, a symptom that you're going to be assessing for is confusion. Calcium is another need to know. Value is 4.5 to 5.2 milliequivalents per liter. This is needed for blood clotting and skeletal muscle contractions. It is regulated by the parathyroid hormone and also vitamin D. Calcium is excitable to the nervous system, so hypo, you will have weakness. Lack of coordination would be with hyper. Magnesium is another electrolyte that you need to know. Normal range is 1.5 to 2.5. And magnesium acts like a depressant. Usually when you start talking about magnesium, you pick up immediately deep tendon reflexes. But it's interesting because magnesium is a smooth muscle relaxer. And so if you think about where smooth muscle is in your body, your diaphragm is smooth muscle and your bladder is also smooth muscle. So hypo would be hyperactive deep tendon reflexes, and hyper, because it's a smooth muscle relaxer, could decrease respirations as well as decrease urine output. And what you're going to see with deep tendon reflexes is absent deep tendon reflexes. The next piece when we're talking about fluid volume deficit to begin to talk about is assessment. What are some things that we're going to see if we don't have enough intravascular circulating volume, fluid volume deficit? Weak rapid pulse, so they're going to be tachycardic. They're going to be hypotensive initially, again because of the lack of intravascular volume. You might see increased respirations, going to have poor skin turgor. You might see an increased hematocrit and an increased urine-specific gravity. When we're talking about hematocrit, the normal values of hematocrit are in the ranges of the 40s. Women are usually 40 to 46. Men are usually 42 to 48 for hematocrit. The higher the hematocrit, the drier they are intravascular. And then when we start talking about urine-specific gravity, normal urine-specific gravity is 1.010 to 1.030. Again, the higher the specific gravity, the drier intravascular the patient is. So some things that we're going to do when we realize that they do have a fluid volume deficit, we're going to force fluids. Usually isotonic IV fluids, and when we talk about isotonic, 0.9 normal saline is the fluid of choice. You could consider giving LR because it's also an isotonic fluid. You want to be continuing to assess intake and output. And again, normal intake is 6 to 8 8-ounce glasses of water a day. So we need to make sure that we're not only giving them what is normal, but above and beyond to help maintain their intravascular volume. You want to assess daily weight, assess skin turgor, that you shouldn't be seeing tenting on the skin. The skin, when you assess turgor and you pinch, it should be quickly and elastic back to the surface. You want to check urine-specific gravity to make sure that it's within the normal range. The next topic is fluid volume overload. When we start talking about fluid volume overload, we have too much fluid in the intravascular space. So we're going to have bounding pulses, we're going to be hypertensive, we're going to be short of breath, and now we're going to bring in airway and breathing. Airway and breathing are affected when you're starting to talk about fluid volume overload. what's happening here is there's too much volume intravascular, and it's not being perfused through the heart and being excreted through the kidneys, so it's backing up in the lungs. Lung sounds that you're going to hear are going to be crackles or rales. Rales is another term for crackles. You're also going to have some peripheral edema. Again, it's not pumping well, so it's going to start pulling peripherally, so you're going to start to see the peripheral edema. You're going to see a decreased hematocrit in BUN. Again, everything intravascular. You've got too much fluid on board, so everything is going to be diluted. Some things that we do to treat fluid volume overload, we would administer diuretics. Again, you could try Lasix or aldactone, great diuretics. You really need to consider labs when you're administering Lasix. It is not potassium sparing, and there could be other complications associated with that if the patient is on multiple medications, such as DIG for cardiac, which most of these patients usually have some form of DIG. DIG can become toxic if potassium is not within a normal range. So please safety watch when you're administering diuretics. Again, you want to restrict fluids and sodium. Sodium tends to attract water, which creates more intravascular volume. You want to continue to assess breath sounds and support their oxygenation needs. Check for any peripheral edema. And you want to position the patient in semi-Fowler position. Again, supporting airway and breathing is your priority. So if you position them in semi-Fowler and they're short of breath, you might have to increase the head of the bed up to 90 degrees and give them some oxygen support. You need to maintain airway breathing as well as circulation. The next topic is diabetes insipidus. When we start talking about diabetes insipidus, the assessment findings that as a nurse you're going to find excessive urine output, severe dehydration, excessive thirst, weakness, and weight loss. When you start talking about diabetes insipidus and SIADH, which is the syndrome of inappropriate antidiuretic hormone, they clearly are, where does the water go? So in diabetes insipidus, the water is being excreted from the body. If you're losing lots of water, then everything becomes heme concentrated. So your electrolytes are going to be heme concentrated when you collect them because of all the water that's leaving the vasculature. One of the main causes of diabetes insipidus is head injuries because of the pituitary. The pituitary sits in the head, and it has to do with diuretic hormone, and so what's actually happening is you're peeing off all of the water. Some things that we're going to need to assess for diabetes insipidus, we need to continue to monitor intake and output, daily weights. A particular piece of assessment that's very important with diabetes insipidus is to check urine-specific gravity. Because we know that with the diabetes insipidus we're losing water, specific gravity is going to be very low. The specific gravity of water is 1. Normal specific gravity is 1.010 to 1.030. So as they come closer to 1, because really what they're losing is water versus electrolytes, that's one of the most key points to help confirm that the patient actually does have diabetes insipidus. One of the treatments for this is called pitressin, and pitressin is a good treatment because it causes renal vasoconstriction and helps to conserve the water loss. The next piece that goes along with diabetes insipidus is SIADH. SIADH is syndrome of inappropriate antidiuretic hormone. Some symptoms that you're going to see with this are headaches, lethargy, changes in level of consciousness, tachycardia, and decreased urine output. In this particular piece, the kidneys release renin. Renin is converted to angiotensin 1. The lungs convert angiotensin 1 to angiotensin 2 so that the kidneys then can release water. Well, due to some pulmonary complication, whether it's a pulmonary tumor, pulmonary hypertension, angiotensin 1 doesn't convert to angiotensin 2, and so the water is kept. It is not excreted. So ultimately what happens is you have fluid overload in the intravascular space, and so because of this excess water that's kept on board, you're heme dilute in your electrolytes. So when you're drawing lab values, you would expect to see this delusional state. Again, SIADH, if you remember, is linked to pulmonary tumors, pulmonary hypertension, because of this lack of the conversion due to the cells in the lungs. Some things that we're going to continue to assess for is level of consciousness. We need to check sodium levels. Again, when we were talking about sodium, 135 to 145 is the normal range. Whether you're high or low, confusion is a side effect. So you're going to start to see confusion if their sodium is out of range. Continue to check INO, daily weights. You restrict water for these particular patients, and really it's 500 to 600 cc's per day. You might consider administering diuretics to help get rid of the excess fluid. The other piece is because the sodiums are usually low, because they're heme dilute, you would consider giving a 3% sodium IV to help maintain their intravascular sodium levels. Hypertonic solution of this 3% will actually help to keep the sodium intravascular, so that you're not going to see a lot of the signs and symptoms related to the excess water on board. We get to the next topic, which is hypokalemia, which is low potassium less than 3.5. You're going to see muscle weakness, you're going to see dysrhythmias, and you're going to see some increased sensitivity to digoxin or digitalis. One of the other important pieces then, when you're talking about potassium being low, we're going to need to replace the potassium. There are some rules. You shouldn't give greater than 40 milliequivalents per liter into a peripheral IV, and the patient should always be on a cardiac monitor. You should also increase dietary intake of potassium. Oranges, apricots, raisins, and celery are some good choices for that. Hyperkalemia, which is the opposite, so now you have too much, it's greater than 5. You're going to definitely see ECG changes. You might see some diarrhea, you might see some nausea. And again, if you're seeing diarrhea, that's your body trying to get rid of the excess positive ions. The nausea, again, your stomach acid, you're thinking about acid-base balances. So it's your body's way to kind of compensate for the high potassium. You would restrict the intake of potassium. You would consider K-oxalate. K-oxalate, again, causes diarrhea, trying to get rid of the positive ions, the potassium. You might consider calcium gluconate and sodium bicarb. In an emergency situation only, you would consider bicarb or calcium gluconate. You would try the less urgent or emergent types of treatment, which would be K-oxalate. You might consider peritoneal dialysis as well to help pull off some of the high potassium, and consider some diuretics such as Lasix, because you know Lasix is not potassium sparing, so it's also going to eliminate potassium from the body. Hyponatremia is the next electrolyte, and when we're talking about hyponatremia, it's less than 135. Nausea, muscle cramps, again, confusion. You're going to see some increased ICP, again because of the intravascular spacing, and sodium actually attracts water, so you're going to see a decrease intravascular with hypo. Again, you're going to monitor intake and output, daily weight, increase sodium-rich foods, water restriction, again, to help with that delusional state. You might consider 0.9 or LR as IV fluid replacement. Hypernatremia, which is greater than 145, again, disorientation, confusion, thirst, dry mouth, sticky mucous membranes, tachycardia and hypertension are symptoms that you're going to see. You're going to monitor intake and output, daily weight. You would consider giving a hypotonic, which would be 0.45 sodium chloride or D5 in water, and you would restrict sodium in the diet. Hypocalcemia, which is low calcium, calcium less than 4.5. You're going to see tetany. You're going to see also two different signs, Trousseau's and Tchaikovsky's. Trousseau's is actually if you inflate the blood pressure cuff greater than 20 millimeters of mercury than the normal blood pressure, you're going to see carpal spasms 2 to 5 minutes. Again, recognizing that that's tetany. Tchaikovsky's sign, which is tapping the facial nerve anterior to the earlobe, just below the zygomatic arch. You're going to see that facial nerve twitching, again, is relevant to tetany. Hypocalcemia, again, we're going to have to give some calcium. Oral calcium supplements. Orange juice helps to absorb the calcium. Might consider calcium gluconate IV. Again, you're going to have to consider any kind of seizure precautions for a safety need of the patient. When you're giving calcium gluconate, one important piece is that it's slow IV administration to consider if you're giving that particular medication. Again, seizure precautions, never stick anything in the mouth. You want to make sure that you're maintaining an airway should they have a seizure. Hypercalcemia, calcium greater than 5.2. It really provides a sedative effect on the CNS. Lack of coordination, muscle weakness, constipation, belly pain. You're going to have a depressed deep tendon reflex, and you also could potentially see some cardiac dysrhythmias. Hypercalcemia, what are you going to do? Encourage fluids. You might give 0.4% or 0.9% sodium chloride. Diuretics to help get rid of some of the excess fluid, to help reduce your calcium levels. Might consider calcitonin. Calcitonin decreases the calcium level. You want to get the patient up and moving around. Potentially prepare the patient for surgery for hyperparathyroidism. Hypomagnesemia is the next one, which is magnesium below 1.5. Tremors, seizures, tetany, confusion, neuromuscular irritability as well. Implementation, cardiac monitor. You want to test their ability to swallow. Seizure precautions. You want to increase their oral intake if possible, and that would be through green vegetables, nuts, bananas, and oranges. Hypermagnesemia is magnesium level greater than 2.5. Consider hypertension, depressed cardiac impulse transmission, absent deep tendon reflexes, decreased urine output, shallow respirations. Things to consider is if you're giving them magnesium, stop it. Discontinue any oral or IV magnesium. Monitor airway, breathing, circulation. Consider IV calcium to antagonize the cardiac depressive effect. And when you're considering hypomagnesemia, one piece that's important to consider is patients who have GI upset take Maalox. Maalox has magnesium in it. So another teaching point or another piece to pick up when you're looking at your patients and you're getting their history is, are they taking a lot of magnesium for stomach upset, like in the form of Maalox? Okay, the next topic we're going to discuss is burns and what you need to know. Emergency treatment, care of burns.